Three, two, one. Hey guys, welcome back to the Foam Frat Podcast. Tyler and Sam, and we're going to talk about all things adrenal insufficiency. And actually, I say we, but I'm not even in this one. This was you and Brian,
Mhm.
and it was a great discussion. I watched it. I have some thoughts on it. It's one of those podcasts that I feel like the majority of our listeners are like driving to work or something.
Mhm.
And if you're listening to it without like seeing some of the visuals, it is confusing as hell.
Yeah, it is. It
Yeah.
totally is. I purposely didn't mention the name of the hormones in between all the stuff because once you start talking about all the acronyms of all the hormones and it would be even worse listening to that without seeing a graph. So I purposely left out some of the details in between, which are not that important anyway. But I was thinking, man, if we start naming off all of this stuff and reading off of like what I put in the blog, I'm like, it's going to be a total crap show. It's going to be totally worthless. So I tried to slim it down as much as I could to just the major parts of it.
Yeah, I don't know. I was thinking about it and I'm like, how do you make this something that you remember? Like it
Mhm.
just seems like something that I would study up on to do a podcast, and then I would probably like lose a lot of it. Where I feel like there's certain information that I retain very well.
Mhm.
This whole Ross cascade, which I found out a way of saying it, the Ross cascade and saying instead of
Oh,
saying Ross system.
sure.
But that whole cascade, like that makes sense. I get that, right? So like
Mhm.
your body is trying to control the amount of volume it has. And
Mhm.
so you have renin, you have aldosterone, and that whole system makes sense to me. That
Mhm.
when the kidneys start noticing they're not getting perfused that well, they start noticing that maybe the sodium is elevating or something, they'll
Mhm.
start to, and what is that called? The juxtaglomerular apparatus or
Juxtaglomerular cells or apparatus.
yeah,
Yeah.
which is like basically like I think of it like the pressure sensors in the efferent and afferent arteries going into the kidneys. When those notice they're not getting volume, they start to secrete renin, right?
Right.
And
Mhm.
so renin comes out, and then it mixes with the angiotensinogen from the lungs, and then that
Liver.
gets
That one's
oh from
liver.
the
It's
liver, and
always
then
floating around,
it's
and
always
then it goes
floating
to the
around.
lungs next.
What's that?
As a yeah, the now I'm forgetting what angiotensinogen. That stuff's always floating around. Apparently, from what I understand, maybe that's not right, but apparently, I thought it's like always floating around so that when the renin does get released from the kidneys, it's like already there. I'm pretty sure because I don't think the liver has to sense the pressure, so I think it's always there. And then the ACE happens in the lungs.
Yeah, and I always think of the ACE in the lungs, and the way I remember that is because people who are on ACE inhibitors get like that dry cough that
Oh, sure.
from because they don't break down the bradykinin as much.
Mm,
And so that process makes sense, and then you once that happens, you kind of you get some vasoconstriction, and the ADH gets secreted, so you
mm,
stop peeing, or yeah, the or yeah, ADH gets
mhm.
released. So that
They
all
get
makes sense
thirsty.
to me. What's that?
So they get thirsty.
They get thirsty.
Mm,
Yeah. Um, but what was interesting to me is I remember listening to an MCRIT episode where they were talking about a patient who is hypotensive, and you're like trying everything you can to figure out why they're not responding to
mm,
pressors, and you're going up on your epi and you're going up on your levofed. And one of the things that Dr. Weingart mentioned in that was trying steroids at some point. And
mm,
they'll do like pulse dosed or stress dose steroids,
mm.
and I always wondered why. Like, why does inhibiting the immune system, like with steroids, what makes them actually increase their blood pressure with that? And it all started to make sense to me when you start diving into how those steroids, how that cortisol actually makes the heart more sensitive to the catecholamines that are
Mm.
circulating.
Yeah,
And
and the
so
vasculature too. I mean, the vasculature can become like vasodilated, and then some of that vasoconstriction in the periphery doesn't work too. So it can be like a twofold effect of pressor unresponsiveness. And so, yeah, that was something good that Brian brought too. He's talking about the stress dose pressors and stuff like that. But yeah, go ahead.
well, I was wondering like what the event of people, or how often people who are in sepsis would meet the criteria for adrenal insufficiency.
Sure.
Because we talk a lot about catecholamine depletion, right? So like
Mhm,
you give somebody ketamine and you're like, oh, that's gonna, if they're in a shock state, it's gonna deplete their catecholamines. But I think about the person who is on, a bunch of pressors, they're septic.
mhm.
I gotta think that they would probably be getting pretty close to meeting the criteria for adrenal insufficiency. And I just looked up a couple studies to see how often that was, because that's something I'll see more often than I'll see somebody with Addison's or,
Oh, yeah.
an adrenal crisis. And I like how you started off your blog by saying like sometimes like we may not know, we may think we never see it because we don't really know what to look for,
Mhm,
and it could be staring right at us and we would
mhm,
not know because we're not thinking about it. But it doesn't have to be somebody with like your chronic adrenal hyperplasia. It could be a
mhm,
patient who is in sepsis and has adrenal insufficiency.
mhm.
It's interesting that you decided to do this, and I know you didn't know that MCRIT just put out a podcast on
No,
adrenal
I just found out
insufficiency. I know, I just
moments
told
before
her.
we started recording this. I was like, "Are you serious?"
But he was talking to a physician. I believe it was a uh, endocrinologist. Yes, yeah, endocrinologist. Is that
Mhm.
how you say that?
Yeah.
Endocrinologist. Yeah, and she was saying that she's seen it even in people who get like their loved one dies and they have this huge emotional response that they can go into this adrenal crisis as well, or adrenal
Yeah.
insufficiency.
Yeah,
I
like
thought that
almost
was
like
really
adrenal
interesting.
exhaustion almost.
Yeah, exactly.
Mhm,
So I think that it is good to review. I wonder how much of it I'm going to remember, but when I'm working down why a patient is not responding to pressors and I'm like looking at like the iCal and you're going down that list, this
mhm.
is definitely something to keep on there, is that it could just be that they need steroids.
Yeah. Once you start seeing these pathways and you even just understanding the pathways of aldosterone and cortisol, once you understand where that stuff or how that stuff is acting on different parts of the body and you understand that pathway, your brain starts to make that connection a little bit and it starts to become like I remember when I started learning about like I don't know, acetylcholine
Mhm.
or, epinephrine or something like that. And then you find out, oh, epinephrine, it hits these different, it has alpha 1 properties and beta 1 and beta 2 properties. And it's like, whoa, beta 2 does a different thing in the lungs than it does in the vasculature. And it's like, that's really weird. And there's all these different components to it, but we just take that stuff for granted because we're so used to like anybody who deals in emergency care, pressors is like a second nature. You're just like, oh, this one these adrenergic receptors, this one squeezes, this one rate, all that kind of stuff. And I guess we don't administer that many hormones that have to do with this kind of stuff, so we don't think about it besides steroids, pretty much. But usually when those aren't something that is this emergent treatment. Usually the steroids are like, okay, we have the COPD or asthmatic, and we hammered them with some epi and some duonebs and mag. Oh, and steroids, not that, steroids actually should go on like super fast and soon
Yeah.
in the call, but it's sometimes like this other thing, like, oh, we got to put the cherry on top when actually, steroids are super helpful. But it's not one of these things that's like, if I don't give them this steroid, typically, their blood pressure won't go up and I'm going to fry their kidneys where you need to know that with pressors. So I think it's kind of it's like how valuable is the information versus how complicated is it? But once you understand the pathways, I think it becomes a little bit more high yield. Um, I think that I've missed not an adrenal call, but I think I've missed an endocrine call or two. Brian and I were actually thinking about doing a separate podcast, and I won't tell you about the case because I might save it for the podcast. But it was a rather complicated patient, and I think it was an endocrine patient that everybody missed. So it can get kind of complicated, but it can definitely be super useful too.
I had a flight a while back with a kid with CAH, with the adrenal hyperplasia, and they gave us hydrocortisone to push if he were to become hypotensive.
Mhm,
And I guess like they take that like sometimes 4 to 5 times a day, like to
mhm,
keep their cortisol levels up. But it was interesting because I looked into what is hyperplasia like.
mhm.
If the kidney, if because hyperplasia is where the adrenal glands are huge. I mean, they're just ginormous on top of it. Looks like a big sombrero
Mhm,
on top of the kidney. And I was like, well, why is there an insufficiency? Like,
mhm.
if it's that big, that sucker should be secreting all
You
kinds
should
of,
have too much.
yeah, too much. And it's interesting because it does produce a lot of androgens,
Mhm.
and that's why you'll see, like, these kids are huge, they
Mhm.
look like
Yeah.
they're weightlifters,
Yeah.
but there's no checks and balances to make those androgens stop producing, and so that's
Mhm.
why it gets so big is because it's just literally filling up with the androgen hormones because you
Yeah.
don't have the renin and aldosterone
Mhm.
saying, "Hey," or cortisol and
Aldosterone,
aldosterone telling it to pump the brakes on it. There's no
yeah. Mhm.
negative feedback in that.
Mhm.
So that's why they get so big. So I had to wrap my head around that, like, oh, okay,
Mhm.
that's why.
Yeah, those androgens come from that base layer, and I don't have it up in front of me anymore like I did with Brian. So I think that's called, what is the bottom one? The reticularis, the zona reticularis, maybe that does the
No,
androgens. I
that
think it's
doesn't
the
sound
third
right to
one.
me.
I know it's the third one down because I drew it. It goes like the aldosterone, cortisol's in the middle, and then I know that the androgens are at the base of
Don't we
the
have the picture right here? Is this it?
Oh yeah, there it is. Zona reticularis, androgens. Yeah, so that little purple layer
Did
right
you
there
write
at the
that with your
bottom
left hand or
before you get to the medulla, which is the what was that?
I said, you write that with your left hand or what?
That's exactly what is this the good one or the bad one? I think this is the good one. So Brittany Granfield roasted me. She messaged me on Slack and she's like, "I proofread your blog." And she's like, "Everything was really good, but to be honest, your handwriting completely sucks." And so that picture is the fixed version of my handwriting. She's like, "Try writing in all caps." And I'm like, "Okay, I'll do all caps." And I sent it back to her and she's like, "It's marginally better." So that's me trying to correct my handwriting. You didn't wanna see the before picture.
Man, think
Actually, I
about it.
think you
We
can do it.
never write. Like, how often do you actually write now? Like, never.
Gee,
You sign stuff, you do
notes.
signatures.
Yeah, notes. And I do take, like, notes and stuff on my iPad or with a pen and stuff like that, but, yeah, not very frequently. Not when somebody besides me has to read it.
Yeah.
Never. Like, I never have to write something out and somebody else has to interpret it very well, you know?
It's
Very
like a
rarely.
grocery list.
Mhm.
Oh, look at that. We
So
just synchronized our coffee sip at the same
Mhm.
time. All right, so let's roll the podcast. Your interview
Oh, do
with
you wanna
Brian.
before we go to that though, the thing tomorrow, the educators thing.
Yeah. Oh, yeah. I was gonna get to that, but psh, okay.
Well, let me give you a few more seconds to gather your thoughts, and I'll wait.
All right. I was gonna say let's roll the podcast, but while you're watching that, know that if it's not making sense, you got to go stare at these pictures for a little bit. A little bit. You got to let it marinate a little bit. And then I would also say that you could go to YouTube and watch this if you're just listening to it. So that way you can see some of the pictures and stuff. And then also, sometimes you just got to go watch like some of those Khan Academies where they like draw it
Mhm.
from like scratch and they go through it. And I feel like if you do that and then set an appointment in your calendar in like 2 weeks to review it again, to do some spaced repetition, maybe you'll start to retain some of this stuff. All right. So quick mention tomorrow at God, I want to say it's 9 a.m., but I
I
got to look
thought
again.
that's what you told me was 9
I know.
Central.
I think it is 9 a.m., but I just want to make sure we're doing the content creator workshop. So, our learning management system has the ability to make cool thumbnails, graphics, quizzes, upload your own videos. And so, what we wanted to do was teach everyone how to use it. Yeah, it's 9 a.m. Central, goes from 9 to 10. Sam and I are going to be hosting it. It's a Zoom webinar. And so we'll put the link into the show notes, but also in our weekly update email we send out. It'll be there as well.
Mhm.
It's free, and you can learn how our learning management system works, and we'll show you how to make quizzes. And at the same time, we're also just showing you how we do a lot of our animations and graphics and stuff. So we would love to see you there. All right, man, let's roll it.
Let's roll it.
Oh, one more thing. No, I'm just kidding.
Brian, welcome back to the Foam Frat podcast. Last time you were on here, you and Tyler were talking about ECMO physiology and stuff. And
Yeah.
the reason I brought you on this time is because you teach a class on adrenal insufficiency, adrenal emergencies, both ways actually.
Mhm.
And so I thought we could have you probably don't even need to read the blog before we before we talk about this stuff. So um yeah, welcome back and
Thanks, man.
tell us what did you call that talk that you did on the adrenal insufficiency?
I did actually 2. I did hyper and hypothyroidism. And
Mhm,
then with hypothyroidism, I touch on, the adrenal component that can be involved as well. And I think this endocrinology stuff is really interesting from the fact that it's really not taught about,
mhm,
or if it is taught about, it's incredibly minimal.
mhm.
Uh, so this is a topic that I think hyperthyroidism, hypothyroidism, and adrenal insufficiency or even adrenal crisis is really not something that a lot of pre-hospital providers have a experience about. And I know we were talking earlier before the podcast is when somebody says adrenal insufficiency or adrenal
Mhm.
crisis, at least in my head, the only two things that may come to mind is Addison's disease and then using etomidate.
Yeah, pretty much those 2, and we were even saying before, if somebody draws a picture of a kidney, they never even include the adrenal glands or anything like that because that's how frequent I think we think about them so infrequently that we even forget that they're there because you look at a kidney and how often you're like, "Oh, hey, where's the adrenal glands on top of that thing?" They're just, frequently forgotten about. So, I was gonna put just to jump into some of the anatomy here before we get talking about the cortisol and the, aldosterone issues. I had this picture of the anatomy here. Here it is. And so with this one, I'll try to, like, get out of the way of the picture a little bit. I'm, like, peeking around it here. So if you guys are watching the video, there's these 3 zones here, zonas, glomerulosa, fasciculata, and then just forget about anything underneath that because we're talking about the first 2. The first layer, the most outer layer of that thing makes aldosterone, and then the layer below it, which is actually the thickest layer in the middle, that zona fasciculata makes cortisol. So pretty much 2 outer layers to this adrenal gland, one makes cortisol and one makes aldosterone. And when anything happens that makes them essentially not secrete that stuff, not send it out into the blood, we have huge issues. So I was thinking maybe we could start off talking about the aldosterone a little bit. And this isn't always present in the adrenal crises or adrenal suppression or anything like that. But it is if it actually affects that, if the disease is actually inside of that gland, like you have like Addison's disease, or one of the ones I put a video in here of CAH, so the congenital adrenal hyperplasia, and Dr. Antevi does a good video on that. So I linked that in the blog. It's in the refresher as well, where he goes to somebody's home. It's actually a really cool video. He goes to this kid's home. I think he's like 8 or 10 years old or something
Mhm.
like that. And his sister's there. She's really young too, and they're teaching, how to treat him with his little emergency Salucortef uh, kit and stuff like that. But yeah, I was thinking we'd start talking about aldosterone first. So why do we need aldosterone? Like, what does this stuff even do?
So I think if we're talking about aldosterone versus cortisol, is aldosterone's probably one that people are going to be more familiar with just because of that renin angiotensin system. And aldosterone really normally maintains the body's salt balance and blood pressure. So when a patient has, decreased blood flow, specifically in hypovolemia, it's going to cause the body to conserve, or the kidneys to conserve sodium and to secrete that potassium and the hydrogen ions. And again, the aldosterone is regulated by that angiotensin aldosterone system. And this is the
And you
one I
can't say RAS system because I made
no,
a
no, because
post
then you
on it
start
about
thinking of
it's
the
it's
other
so hard
scoring
not to say
system.
that. RAS system rolls off the tongue, and I loved everybody's examples they were given on that Facebook post. ER room,
Yeah,
or
yep.
there were like 20 of them. I'm like, yeah, we double say a lot of stuff, and RAS system is is one of them. But it's so easy to say because you feel like you're not finishing the sentence when you say RAS, and their RAS is screwed up. It's like their RAS, their what?
Y
The RAS system. Oh, okay, yeah, sure. But yeah, so that's a good point. So yeah, this stuff causes us to retain sodium. So you're talking about that sodium potassium pump. So
mhm,
pumps sodium back into the blood, pumps potassium out. And then we always know, I think, we probably learned about that first time we thought about diuretics. If we learned
mhm,
about those, anything that causes sodium reabsorption sucks the water with it. And so that's where we get really 2 of our big issues with the aldosterone stuff is that if it doesn't reabsorb that sodium, water doesn't follow it, and then you end up peeing a bunch of water out and you become hypovolemic. So that's like our
mhm.
first thing is like the sodium is low, and that caused them to not have enough water. And then you touched on the second thing, which was if they're not pumping potassium and sodium in the right direction, then they're just going to be they're not even they're not even mismanaging it, they're just keeping it because
Yeah.
it's not being pumped in the opposite direction. So they're not excreting potassium, they're excreting too much sodium, and then that the water is following that. I had this picture up while you were talking about it a little bit of the RAS. Ooh, I was gonna say RAS system again. That's so difficult. Here it is of the RAS, and I only put RAS on the graph. So you have the angiotensinogen and renin that comes in angiotensin from the liver, combines with the renin. The lungs use ACE, the angiotensin converting enzyme. It's angiotensin 1. That's converted by ACE into angiotensin 2. And that stuff does a bunch of stuff by itself. That's where you get vasoconstriction. It makes you thirsty. It maintains baroreflector reflexes. In itself makes you retain sodium and therefore water. But the aldosterone is a big part of that as well, because that angiotensin 2 is going to cause those adrenals to release that aldosterone. That aldosterone is then going to cause you to retain that stuff. So that could be, some of our beginning symptoms where somebody has just complains of maybe weakness, just crappy dehydration feelings and things like that. And like you mentioned too, they can have a little bit of a problem with their with hydrogen and bicarb too, because that's
Hmm.
another thing that the aldosterone does is it not only does it pump potassium and sodium in the correct directions, it pumps hydrogen and bicarbonate in the proper direction. So it wants to excrete hydrogen and it wants to pull bicarbonate back in. So that's one of those like renal buffers for our pH as well. Did we miss anything with aldosterone? Can you think of anything else?
No, and I think you bring up a good point because when a lot of this endocrinology stuff, again, it's not touched upon in great detail, in our initial paramedic education, and a lot of refreshers don't really touch on this. And this is what really drove my interest because
Mm,
a lot of these endocrinology based stuff, their presentations are incredibly vague.
mhm,
So it really makes it a really big mimicker, and Adrenal Crisis really fits that as well.
mhm.
Now, I think when we talk about cortisol, that's where I think people start thinking of, hey, if I give a dose of etomidate, am I going to put a patient into
Crisis or whatever.
crisis? Yeah. And I think with that is it's real important to think of, uh, what does cortisol do? And cortisol is really, the body's response to any type of stressor, whether it's trauma, sepsis, and what cortisol does is it really influences a couple of different things. It's the immune system, vascular tone, as well as metabolism.
Mm,
And that's where, we start thinking of a cortisol level and different types of issues, but more importantly, any type of stressor to the
mhm.
body.
Yeah. I listed some out and because I certainly don't have these memorized. I don't have the cortisol, functions memorized. So this is what I put in the blog was that I picked 4. Is it 4? It's 4. Liver, it's going to do in the liver. It's going to do gluconeogenesis and
Mhm.
glycogen storage, which those metabolism terms sometimes get confusing. So glucose neo like beginning genesis. So gluconeogenesis, we're making glucose out of fat, we're making it out of protein, and then if we can get those linked up into long enough chains, then we can store those stuff. So if something goes wrong there, if the cortisol isn't acting on the liver, if you're not making sugar out of other stuff, you're not storing sugar, like that's a recipe for hypoglycemia. So there's one of our next symptoms is, now not only do we have the sodium issue, we had the hydrogen pumping issue, we had the water issue, we had the potassium issue. Now we have a glucose issue. So sodium, potassium, glucose so far, and blood pressure because of the
Mhm.
water. And then pancreas, plays into this one plays into the glucose stuff as well because that cortisol will decrease insulin secretion.
Yep.
And so if the cortisol is not there to tell the pancreas to chill out a little bit, that pancreas is going to start pumping out insulin. And we already had no gluconeogenesis. We already had no glycogen storage. So now this thing's pumping out too much insulin. That's 2 things right there that can dump their sugars. So that's something that's on your differential if you find anybody hypoglycemic.
Yeah,
And
and I
then
think with
you were talking about this a little bit, the cardiovascular increased sensitivity to those catecholamines, especially vascular tone. And then of special note with what we're talking about with sodium and potassium again, sodium reabsorption, potassium excretion. So we get more of the same issue essentially where we're trying to maintain the sodium water balance and then plus the potassium. So all those things pretty much come back to the same set of symptoms.
Mhm.
Sugar issue, sodium and water issue, potassium issue, and then I guess going along with the water and the sodium stuff, that's what's mostly causing their hypotension.
Yeah, exactly. And I think this is where you really have to start thinking of, how these patients present, specifically, patients who have, repeat bouts of hypoglycemic or their refractory hypoglycemia, patients who have vasopressor resistant shock. This should always start making you think of, hey, is that little gland on top of the kidney somehow responsible for something going on?
Mhm.
And I think, it does not get enough respect.
It gets no respect.
It gets no respect as Rodney says.
Yeah. Um, so to get these different issues where for some reason the body is not either excreting or secreting cortisol or aldosterone. There's a couple different ways that it can happen. Before I put this picture up, and you guys, for those of you who only listen to the audio, you can look at it inside the blog itself. There's primary, secondary, and tertiary. And so it goes kind of three across, and then it also goes three down, where it starts with the hypothalamus, and then below that's the pituitary, and then you have the adrenal gland. And if you're not looking at this graph right now, you'd probably be like me and like already thinking, okay, this is getting ridiculous, right? So hypothalamus triggers the pituitary, triggers the adrenal. So it's like one, two, three. And if any one of those screws up, one, two, or three, it's like going from top to bottom. So it's like hypothalamus is broken, never tells anything to the pituitary. Or move it down. Hypothalamus is working, but the pituitary is broken. Well, then that's the break in the chain. Or maybe both the hypothalamus and the pituitary are working and they send messages down to the adrenal, but the adrenal itself is diseased. And then it's just like beating a dead horse. You can send all the signals to the adrenal to try to get this thing to work, but it's not going to. So now I'll put up the graph after we've introduced it a little bit. So here's the graph. I tried to make it look as friendly as possible. And so what you guys are looking at here is, and again, if you guys listen to the audio, this is a reason to go subscribe to the YouTube. But primary, essentially what's not working is adrenal. Secondary, you go one layer up. So the pituitary is not working. And then you go one layer up for tertiary. And that's the hypothalamus. And with these, something really interesting is on secondary and tertiary, there is no there's usually not an issue with aldosterone, and the reason for that is because the aldosterone is primarily regulated by RAS,
Mhm.
and it didn't say RAS system, and so the RAS is primary. It cares for something like 2/3 of the aldosterone stuff. So the aldosterone can usually function as long as the adrenal itself is not diseased. But the hypothalamus, the pituitary and stuff, they're super responsible for how much cortisol it releases. So you can have an issue at any one of those layers, and you can start to have cortisol issues more frequently. But the usually the adrenal gland itself has to be damaged in some way for there to be both a low cortisol and low aldosterone, since otherwise you'd have to have a disease of two different pathways at the same time to get low cortisol and low aldosterone. If that doesn't make sense, just listening to it, stare at the graph for a little bit and it'll start to make sense. So that's kind of the axis of this disease. Can you think of any other ones? I mean, I know we talked about like CAH, Addison's disease. You talked about the adrenal suppression with we should talk about discontinuing steroid use.
Yeah, and I think so when we're talking about adrenal insufficiency, I think, the first thing everyone's gonna think of is Addison's disease.
Mhm.
That's really the number one cause of primary adrenal insufficiency. But what you really want to think of is any patient that is on chronic steroids is, start thinking of adrenal insufficiency. And this is where it becomes confusing because it's not the patient taking chronic steroids, it's the patients that have been
Mhm.
taken off of chronic steroids.
Mhm.
Because that can actually throw them into adrenal insufficiency, which is where this is coming from.
Yeah. So with the various kind of levels of what would cause this. So is it primary Addison's or is it whatever? Just going a little bit more into the discontinuing steroids thing. It's a actually a pretty decent example because the way you can think about any of these hormones in the body is that there's always an on off switch. And so if you have a ton of something, like let's say you have a ton of cortisol, and you guys would see that in that graph if you look at it, those broken red lines that come back up to the hypothalamus, come back up to the pituitary, those are because there's no cortisol. And so it's never coming up to the hypothalamus. It's never coming up to the pituitary to say, hey, we got plenty of cortisol over here. Like, check it out. Look how high the levels are. And then once the brain realizes that, it's like, oh, cool. Look at all this cortisol that's going on. Like, we don't have to send any messages down to the adrenals to secrete more. But then if they did get low, they'd be like, oh, hey, I don't sense any. Let's send some messages down there and tell them to create some more. Think about anybody who takes, like, think about one of these crazy Mr. Olympia dudes on everybody knows these guys juice up, right? So these, they're on a ton of human growth hormone. They're on a ton of testosterone, exogenous testosterone and stuff, all these different things that they take. But because they're putting that into their body, the body stops making it because there's this super therapeutic, amount of, let's just say, testosterone. Well, then, the androgens, the testicles in a guy, they're going to be like, well, we have all this stuff. We don't have to make it anymore. That's exactly what happens with these like glucocorticoids or mineral corticoids and stuff, where they take these, prednisone, for example. They take prednisone every day for their asthma. And then they run out and they forget to get their prescription. They're on vacation and they've gone days without this high dose steroid. Well, the body is going to try to adapt to that. And maybe it can start, depending on the dose, maybe it can start making that again. Or they'll go into adrenal crisis because they've just lost all these steroids inside their body, and there's the body is not kicking in to replace that stuff, and you run into all the issues we were just talking about.
And I think you bring up a good point because that's the patients that you're most likely going to see this in, but it can really happen in anybody. So,
Mhm,
a patient has asthma, they're placed on a steroid taper,
mhm,
and, that can throw them into adrenal crisis. But the other ones you also want to think about the people who get steroid injections,
sure.
things of that nature. Not as common, but it definitely can happen. And I think that's important from a wide differential type,
Oh, yeah, for
looking
sure.
at it from that standpoint.
Yeah, and so that adds a few questions to your, routine assessment. If you see somebody who's like hypoglycemic and the blood pressure is low, and you're like, this is kind of, there's multiple issues going on here. It kind of seems like maybe like a endo thing or something. That would be a question to ask. Do you take steroids? Has there been any adjustment in your dose? Have you stopped taking steroids for any reason? Did you run out and not refill? Like, what medications are you on? And if they've recently had a big adjustment in dose or they didn't take it or something like that, that could be the reason why, yeah, the sugar won't stay up and the blood pressure won't come up, and you see
Mhm.
some peak T waves and you're like, "Oh, this is actually starting to look kind of complicated and serious." So those are the
Yeah.
things that could get you into that ballpark where, yeah, asking about stuff like steroids might be advantageous. So that's one treatment, right? So we'll talk about the steroids last, but just to kind of cover those other things real quick, if they have a low, well, so sugar is easy because dextrose most people use in D10.
Mhm.
And then blood pressure, I mean, you're giving them fluids that should help quite a bit because they're usually hypovolemic. Maybe they'd need norepinephrine. So that covers our sugar. We know how to raise a sugar. D10 is responsible. Fluids and maybe norepinephrine for a blood pressure. We said we have to give steroids. I'm just going to put this up real quick because don't think that these things are going to be like given naloxone where they just like shoot up and they're like perfect after they get steroids. I'm putting up on the screen right now. They have Salucortef at home, usually in a kit. They give IM, but look at the time to
Mhm.
peak. Intramuscular, 66 minutes plus or minus 51 minutes. So it's
Yeah.
like, okay, that's a very large range. And of course, IM injections can, vary. Solumedrol, time to IV peak, 50 minutes. Onset usually within an hour. Can sometimes be shorter than that. Dexamethasone is rapid, 5 to 10 minutes. But the ideal one is going to be the prednisone. It's going to be Solucortef. So,
Mhm.
but you can. Brittany Granfield made us a meme for this. It says, "Waiting for my Solucortef to kick in, and I'm having an adrenal crisis." So, follow her on it's Instagram. Yeah, Instagram at Nurse Tanny, but she did a peer review for the blog and she is like, put this in there. Actually, she said, "You don't have to use this if you don't think it's a good meme." And I'm like, "I think it's a great
No,
meme.
that's a
I'm gonna
great
use it."
meme.
But so that's one thing to think about. So they have to have the steroids. That's kind of the fix fest of the cure for this, but it can take a while to kick in. So in the meantime, you're stuck managing the sugar, managing the blood pressure, the sodium, the potassium. Potassium is just our standard hyperkalemic treatments. If you need that, most important would be calcium probably. And then here's the thing that I was thinking about before is that these patients have really low sodiums, right? And so you start giving them normal saline, but it's like if you know this patient is hyponatremic, their sodium is low. I think most people are going to stick with normal saline. This would actually be a use case where you'd probably want to go with the saline instead of
LR.
Ringer's lactate because it's got more sodium in it. Um, Whereas the sodium in LRs is a little bit lower. But do you think there's any risk for like osmotic demyelination syndrome in the acute phase in this patient? I looked up some case reports.
I don't know off the top of my head, but I think from a pre-hospital standpoint, it's not, we're not gonna be giving them that much
Mhm.
normal saline.
Yeah,
But I think, that's something you always wanna keep in the back of your head, with switching those, that sodium load very quickly or correcting that sodium
yeah.
very quickly is that demyelination syndrome.
Yeah, the one of the case reports that I was looking at, the patient ended up being a little bit more complicated. It was a very in-depth case report. I put the link into the blog, and there's two studies in there that talk a little bit about if you can get access. One of them is not open access, the other one is, but it talks about how quickly to correct this stuff. And for those of you who know, like a sodium range is usually like 135 to 145. And so if these patients can present really low, like one of the case reports, I think their sodium is like 104, super low.
Mhm.
And correcting those patients with too much sodium can cause the myelin sheath of their axons to just disintegrate. And so that's not good because they can end up with like long-standing neurological issues. So sodium, anything that is involved in your serum osmolality, so correcting glucose too quickly, like down, correcting blood urea nitrogen too quickly down, correcting sodium either way up or down will all screw you up. So those are like the ones to remember is like if we alter any of these too quickly, we're probably going to cause some type of damage or complication. So one of them was saying like 6 to 8 milliequivalents per liter per day, which if we're handling one of these patients in the pre-hospital setting and you're just giving them normal saline to correct their blood pressure, I don't know how nervous you would be about it because you probably can't test it. And so I guess my thought process would be I want to address the hypovolemia. So I am going to give normal saline, but I would probably, if I really had an issue with this blood pressure, I might go to norepinephrine maybe more like maybe a little bit sooner because that's not going to affect my sodium and it will bring my blood pressure up. And so that could work in kind of conjunction, even if it's not a super high dose, just to kind of assist the fluids in a little bit because I wouldn't want to just hammer and hammer and hammer salt into that patient or sodium into that patient just because I mean it probably won't happen. I don't you probably couldn't do it pre-hospital, but that thought's still in the back of your head.
And I think that brings up a good point, especially from a critical care transport standpoint as well. Is when you're thinking about this and have these patients, you think they're septic, that they may be down a couple of liters, or you've replaced a couple of liters and they're not getting better, and you started a vasopressor, and
Mhm,
again they're not getting better. These patients that have this vasopressor resistant shock should really make you think, hey,
mhm,
is this an issue with um, their adrenals? And
mhm.
from that standpoint, that's where the stress dose steroids come in.
Yeah.
And most of these patients won't be responsive to these vasopressors and these boluses until you actually give them steroids. And as you said earlier, the preferred steroid is going to be Solucortef
Mhm.
because it's both a glucocorticoid steroid as well as a mineral corticoid steroid.
Yep.
So you actually kill, two birds with one stone with that.
Yeah, super important to get those on. Brittany Granfield, one of the reasons that she was interested in doing the peer review for this blog was because she's worked in a children's center before. So these kids come in with congenital adrenal hyperplasia, so CAH, and that's like their one huge thing is they had a goal, almost like you have a goal to uh, you know
A door to
PCI
needle,
time or
or
door to
yeah.
PCI time or some door to balloon time. Like they had a door to Solucortef time or whatever steroid they chose to use, a door to steroid time. They tried to get it on board as fast as possible, and that was one of their markers for are we doing well with these kids? And so that's how important it is to get those steroids on board soon. And so if you don't have Solu-Cortef, maybe the patient does if they're diagnosed, but otherwise you're going to end up using whatever steroid you have because something's going to be better than nothing, even if it's not ideal. So whether you have Solumedrol or you have dexamethasone, just figure out what your dose would be, and if you need to call medical control because it's kind of might be a different dosing for a different size patient or something, always use a reference for that. I purposely didn't put any dosing into there because you're going to have adult and pediatric dosing, and there's usually going to be atypical dosing sometimes for like adrenal issues. So I didn't put any dosing in there because whatever you're doing at the time, you need to make sure that it's right, and you need to consult a reference. So I didn't even dip into that one. But another thing I forgot to pop up on here, we would be remiss to not show a picture of some hyperpigmented patients looking bronze. I don't know I looked up the mechanism for this, and now I can't even remember it. I didn't put it in the blog either. Something to do with melanocytes, something to do with, I can't even remember what it is. Something to do with the lack of aldosterone. Maybe is it aldosterone? Maybe aldosterone either, or cortisol. Something to do with it. It prevents the melanocytes from producing more melanin. So when you don't have it, you get hyperpigmented, and so they even have, and it can be especially over joints. I was reading, just something that we kind of see, but is just a symptom of a larger thing.
Yeah, and that hyperpigmentation is usually gonna be diffuse, and what's interesting, it's gonna be most obvious in the sun-exposed area,
Mm,
but the other thing you brought up is areas of, like, friction and, pressure,
mm.
and as well as mucous, membranes in that image that you just showed. That's gonna be, almost, I think, half of patients will have that, with primary adrenal insufficiency. So
Yeah,
that can lead you onto that diagnosis.
that was always the thing people said about JFK, right? Was
Mhm.
that he always had that nice tan. Not not quite a healthy tan though. His skin looked great. He uses a little bronze for his own good because he had this adrenal, or he had the Addison's disease.
And I always think of Kramer when he was, in Seinfeld when he was, sun tanning with the butter on the roof.
Oh
He
yeah.
comes and looks like a turkey just
Yeah.
because of that hyperpigmentation, that's incredibly, tan.
Yeah, yeah, totally. And so, well, as we're kind of wrapping this up, I guess we did the anatomy and physiology of this thing. We talked about what the cortisol and the aldosterone does and the symptoms that produces, and then kind of why you can do this and how you treat it. So I think that we pretty much covered everything in here. Definitely go check out the blog and stuff. And Brian does a great talk on this as well, and other endocrine emergencies and the refresher for the live classes as well. Which you guys will see some recorded stuff this year coming as well on more adrenal stuff. Was there anything that you missed? What do you think we should have them remember about adrenal insufficiency or crisis before we go?
I think with adrenal insufficiency is a lot of times is most patients aren't formally, diagnosed until after they've actually had an adrenal crisis.
Mm,
So that's going to be the first one. And again, it's very, very vague. So it makes
mhm.
it, just like with a lot of these endocrinology type presentations, there's all of these, they're commonly misdiagnosed. So having that sort of wide differential is very, very important. But
Yeah.
I think that's going to be the key. And then, other than that, I think that's really it. But always consider it with that vaso pressor resistant shock. Patients
Mhm.
that aren't responding the way they should. And I think you'll see. I think this is going to be a topic that you'll probably see more and more of becoming mainstream in the pre-hospital environment, just from a
Mhm.
stress dose steroid administration in patients who may have adrenal insufficiency.
I think that's a good way to end it, man. Thank you so much for coming on and hanging out and taking some time to talk about some endocrine stuff, which is everybody's.
Awesome.
We should do another endocrine next. We should hop back on and do a different endocrine next.
Yeah, I
We'll
think
plan that out.
the endocrine stuff's interesting, and it's definitely not touched upon uh, in most paramedic programs, or if it is,
Mhm.
it's very, very minimal.
Yeah.
And then
Like I
once you
said in my blog,
understand it,
all I thought in the blog when I thought about adrenal stuff was pheochromocytoma and being scared to give people epinephrine.
yeah, and that's and that's the one, like, that's what, less than 0 point or 0.02%.
Yeah.
And then I think the other one, like I said earlier, is people always think of etomidate with adrenal insufficiency. But yeah, I think these are super interesting. While rare, they're interesting, and it's important to keep them included on your differential.
Yeah, totally. All right, man. Well, we'll see you next time.
Awesome. Thanks, man.